Welcome to Heartline, conversations with healthcare changemakers following their Heartline. I'm your host, Dr. Andrea Austin. I'm an emergency medicine physician, coach, and educator. I believe that healthcare needs to improve the quality care that patients receive and that supporting the workers is at the heart of this transformation. I always open with saying that I'm thrilled and excited, and I always am when I'm talking to somebody on this podcast, but it's really hard for me to convey to all the listeners today how excited I am to have the Dr. Victoria Brazil on the podcast. If you don't know her, I don't care what you do, pick up one of her simulation papers, listen to her podcast. Even if you don't know anything about simulation, if you work in healthcare, her work speaks for itself and it speaks volumes and it transcends simulation. She is a phenomenal person. She's definitely changed, expanded my mind on a lot of concepts related to simulation and how healthcare can work better. So, Victoria, it's wonderful to have you on the podcast.
Oh, thank you, Andrea. That's incredibly generous introduction from you. I don't know that now I can live up to this great expectations, but I'll try.
You will. I have full faith in you. So it's so great to have you here. And my joke every time we have someone from Australia on the podcast is you are coming to us from the future. Is that correct?
Well, of course it's correct. It depends on which way you fly, but yes, correct.
Yes. So I'm recording on, let's see, today is Tuesday afternoon in America. What day is it for you?
It's Wednesday morning here.
Awesome. It never gets old. I love that.
I did have a little Australian experience on the weekend. I was doing some running events up in a rural part of Australia. In fact, where I grew up. And on the bathroom door, as I walked up, it had ladies at the top. And then there was this very cute handwritten sign that said, "Please keep the door closed to keep the snakes out."
And that's not really a joke, right? Like,
No,
snakes are quite
they were very
fierce
serious.
in Australia.
So just to reinforce all the stereotypes, yes, we have the odd snake, but believe me, they are not the most dangerous things you can do here. It's like everywhere else, get in a car, and that's far more dangerous.
Yes, that is definitely not lost on. We also share similar backgrounds that we are both emergency physicians as well. Well, what I wanted to talk to you about today, it's kind of funny because I've had this podcast now for a couple of years, and I've never really talked very directly about simulation with our listeners, even though I spend probably at this point around 70% of my time doing simulation. And so I wanted to, instead of having a monologue about simulation, I wanted to have you on because you've been at it a bit longer than me. And at this point, correct me if I'm wrong, you're doing simulation pretty much full time.
Pretty much full time, yeah.
Yep. So you've got just a few more rotations than me. If we use the PGY system, sometimes we joke at this point, I think I'm a PGY 8? No, 9. Oh, gosh. Do you ever use that term in Australia? Have you heard it?
We certainly have, yes. But once you get to PGY 32, it's time to stop counting.
Oh, that's great. For some of our listeners, they may not really know what medical simulation is. And all things, like once you're immersed in something, I'm like, how do you not know what medical simulation is? And especially when I meet another healthcare worker, I'm kind of shocked, but it still happens. So break it down. What is medical simulation?
I think it's a great question to which there's not an easy answer. There is a simple answer, which is simulation is recreating a challenge or an environment in which we do our work and for the purposes of trying to practice it. And so the simplest ones are things like, let's practice doing our CPR on a mannequin. Let's practice intubating a airway head. And that's simulating the task that we might want to practice. And people anchor to that. And that is both a good thing, but it's also a problem because, as you and I know, there are far more applications of simulation. So we might also be thinking about simulation in terms of medical students practicing consulting with patients. And we might be working with humans who are acting as patients who have been trained specially to educate in that forum. So that's simulation as well. Role play is, I guess, one way people are thinking about it. We might also be thinking about simulation as something that's done in a virtual reality environment. We might also be thinking about simulation that's done with a team, either around a mannequin or even around some plastic laminated cutouts in a tabletop simulation. So I think what all of these manifestations have in common is that we are recreating a simulated environment or challenge or task for an individual or a team to do with the purpose of learning, whether that's individual learning, team learning, or organizational learning. One of the simulation activities that I've been most involved with over the last 10 years has been simulation for the purpose of organizational learning. So quality improvement, safety, where we might be using simulation to test out the effectiveness of a clinical process, a clinical pathway, a cognitive aid, the environment, the new facility. And so I think it's both a problem and an opportunity that people don't have a clear idea of what simulation is, because it's many things that maybe what they share in common is very narrow, but the breadth of what they can achieve is very wide.
Yeah, I love what you just touched on there about the ability for simulation to impact the organization. And I'm finishing up my master's in health professions education. And when I wrote the thesis proposal, which is actually not simulation based, it's on change makers in healthcare, I got exposed to this concept in organizational psychology on single loop, double loop, and triple loop learning. And I see you nodding your head. So would you say that's one way we can wrap our heads around simulation, that the individual is the single loop learning a procedure, a task, and then we take it to the double loop, that team putting it together. The triple loop is that organizational learning that we actually learned when we tested this process out, that we didn't have the correct equipment. And that is really, for me, where the money is at. Not just the money, that is where the meaning is at for simulation.
I mean, there's different understandings of concepts, but in my understanding of Chris Argyris's double loop learning, it's also about understanding why things happen, not just trying to correct things that happen. And I think this is particularly pertinent when we're using simulation for these purposes of looking at an organization, rather than saying, this incident happened, let's write a new policy so that it doesn't happen again. Instead, we can actually use simulation to explore what is happening in the performance in that domain. So if it is, we're getting slow in taking our patients up to the cath lab with their myocardial infarctions, instead of just telling everyone in an email to go faster, maybe we can recreate some of these challenges for teams in the environment and think, okay, what is stopping us going fast? Maybe it's because we've got various safety checks that we're doing. So maybe some of this speed is appropriate. Maybe some things do need more parallel processing and we can speed up. But I think one of the things that I've been quite involved with is thinking about simulation as an environment in which we can explore performance before we then move to thinking about improving performance. So yes, I think more than one loop, multiple loops of iteration and testing are a part of that process.
Okay, I just think I've come up with a decree, if I ever get to decree anything. No one gets to send a policy in a hospital unless it passed the simulation director's desk.
We love that sort of.
Because goodness, there's so many policies that get sent out. And this is where I think trust, and this is where I think simulation can start to insert some of this trust back into the system, is you'll be sitting around, an email will come up and you'll be reading it and your head's about to explode because you're like, that's not going to work. Because the person writing that policy no longer does clinical care. And I'm not saying that to completely undercut what they do, but it actually isn't going to work.
Yeah, and I think this is, you've touched on, I guess, one of the real challenges in contemporary quality improvement and safety science, and that is the lack of this design thinking approach. Mm-hmm. And I think people like Andrea Petrosoniak in Toronto and others who've really thought, how do we take a design thinking mindset and think how uniquely positioned simulation is to be part of that process, where we do think intensely about what is the so-called end user experience, to use the design thinking language, in this case, the frontline clinicians. What actually is their experience? What tacit expertise have they already got that whatever our policy is needs to capture? And by the way, what are the real barriers that are going to be there that you can't just wave away with a document, but which you do have to think about how will this turn from, to use Stephen Shorek's words, the work as imagined to the work as done. And I think we saw this beautifully manifested during COVID, didn't we? When people came out with a lot of probably evidence-based plans as to how we should adjust our care to be COVID safe. But then when it got to the time of doing it, it just didn't work. And because it hadn't been tested. And even if it did work, no one had time to read the 24-page guideline. So we had to think about different materials. And so a lot of us spent time in COVID testing cognitive aids, testing new ways of doing things so that we could prepare and support clinicians to be doing their work effectively and safely, but in a way that was meaningful to them. So I think simulation, one of the advantages is you can create a test bed where you can rapidly experiment and iterate. And that's why this is a good environment to do that kind of work, as opposed to waiting for audit material from the real clinical environment. Maybe we have one cath lab activation a day. As you know, very hard to collect data in the real world, lots of things. But if we want to try a new process, we can probably run 10 iterations of that in a morning in a simulated environment, and we can adjust elements of the challenge according to what it is that we're trying to test. So I think this is an underutilized use of simulation. And I think, unfortunately, we've got into a little bit of bureaucratic minefields of stuff and just this huge amount of, I think it's called safety clutter is the word I've used, where organizations think if they add more in, that will make things safer. But unfortunately, it's just created a lot more complexity in some cases.
Yeah, 100%. I want to come back to that quote that you said. I used to, quote that simulation bridges work as imagined and work as done. And I actually think it goes the other direction too. Imagined, done, reimagined is what I think the beauty of simulation is. I'll give an example to the listener. Our airway equipment used to be separate, and then they put it in the crash cart. So now you need to have the meds open and the airway drawer at the same time. And that was creating like people stacking up, because it used to be the airway people would be removed from the crash cart people. Well, one of the nurses said, oh, well, you just pull the med drawer out and set it on the table. It's such practical things that, how long would it have taken sitting around a table? Would you ever come up with that solution versus just doing what, in some ways, what children would have done, right? And what children do. Children touch things, they play with things. And as adults, I think a lot of times we've forgotten how to do that.
And more than that, Andrea, because I think what you described is exactly what Peter Diekman would call learning from success, the word he uses, which is a big word for me, exnovation, which is instead of trying to innovate into something, actually saying all the expertise you need is sitting in your workforce. So let's exnovate it and let's bring it out to the fore. And so you talk about maybe people have forgotten how to play, but also a lot of simulation facilitators have got the mindset of, we're here to improve you and let's give you some advice about how to be better. Instead of what Peter would be telling us, Peter Diekman, is what can we learn from you? Mm-hmm. How can we use simulation to explore the everyday work of people? And then how can we, through debriefing conversations, extract that tacit expertise so that it becomes visible and hence shareable amongst the team or the organization. And I think that requires a little bit of a stance shift for us as simulation facilitators, because too often I see senior doctors and nurses coming in to teach junior doctors and nurses, and I'm going to concentrate on those two professions in sim. And what they come with is a stance of, I know better than you, so you'll do something and then I'll tell you how to correct it. And I think what this safety to and learning from success approach would say is there is a lot of expertise in the system, and how can we bring that out rather than tell people what to do?
And I want to make this more concrete, and I think this is where we struggle sometimes, is we both believe that deliberate practice has a place. And so with procedural learning, and my learners and my faculty also know that I'm very quick to say that with procedural learning, we don't let somebody learn the wrong way to do a procedure. And we intervene at the earliest moment when they're in that learning the procedure phase to help them not develop a skill that we know that's really hard to unlearn. Unlearning is really hard. Would you say that's a delineation, or how do you explain that to educators, the difference between when to intervene in a procedure versus the simulation?
So I think what you've hit the nail on the head here with is that whatever simulation we're doing, we should be very clear on what we're trying to achieve. And I think, unfortunately, many of us have tried to achieve too many things in one event, whereas in reality, we're far more likely to achieve something if it is a narrow, focused goal that is very clear to the facilitators of the activity and very clear to the participants in the activity. So to take your example of procedural learning, totally. This is something where what good looks like is very well described, very well illustrated, and you can show people videos and you can have a rubric for what is the right way, here's the steps. And so this in some ways, although it is not necessarily easy to do, it is not actually complex performance because there is a very clear right way. And so for that, we want the kind of simulation that is the single loop learning. We just say, here's the right way, here's the gap between you and that. Whereas I think if you're talking about a team full of multiple disciplines and professions managing a complex trauma patient, now you're talking about a very dynamic, volatile, uncertain, complex, ambiguous environment. And here, you're not got a very clear recipe. And it's not as though you guys should have done this. That's going to be a ridiculous thing to say for a facilitator. Instead, exploration, understanding, thinking about the dynamic nature of the interrelationships of the teams and the people within there, and how they will develop some fundamental principles about how they approach the next problem, knowing that we can't ever train for each of the challenges that confront us. So that, to my mind, just means, coming back to the key point, that we have to be really clear on what it is that we're trying to achieve. And we can't run a sim and think, oh, well, some people will learn procedures, plus we'll talk about teamwork, plus we'll be building culture, plus we'll test the environment, plus we'll see if the monitors work in the resus room. I think we've got to be very intentional about what we're trying to do.
So I want to pull back for a minute and start how I normally do. I'm curious about if you can tell our listeners a little bit about your career, how you became an emergency physician, and where simulation entered the story. Was it from the beginning or did it come in later?
So I graduated from medicine sometime last millennium, and I went to work in the Northern Territory, which is a more regional, remote part of Australia, and really enjoyed the variety there. And I think that was why I got into emergency medicine, was just the variety, interesting people, interesting patients, interesting challenges, diversity. I came and did the rest of my training back here in Brisbane, and I think it was around the end of that time that the sim men started to show up around the place. And so I got interested in thinking about the opportunities. I'd been involved in education, so I came from the background of a clinician who was interested in education and thinking this was a modality that I could see being very helpful, largely because of its experiential nature and because of the opportunity to train teams together. And they were the two things that I think drew me towards that. The story from there gets sort of complicated, but for a while, I, as a sideline, ran my own business doing in situ simulation. We dragged some of the first generation sim men over 7,000 kilometres around various parts of Australia doing in situ training in rural and regional hospitals, thinking about how they prepared for emergencies. And that was huge fun, very interesting, very informative. And I think that was when I first started to think there is more to this than just this doctor and nurse thinking about how they intubate an asthmatic. There is much more here in terms of how the team are building their teamwork, but also how this team is also reflecting on the conditions in which they perform, whether that's their equipment, their environment, whatever it is. So did that for a while as I was working in emergency medicine still. And then about 10 years ago, I came to the Gold Coast where I had two jobs. One was at a medical school where we worked a lot more with simulated patients and focused on thinking about simulation as an educational tool for that group. But then the other half of my job has been both as an emergency physician and the medical director of the simulation service at the Gold Coast Health Service. So here the purpose was much more focused on quality and safety goals of the hospital. And so I've been able to compare and contrast the educationally focused sim that we do for the students, which is excellent, and the sim that we do at the hospital, our translational simulation, which is ultimately focused on the organisational outcomes. So yes, of course, we still do courses and workshops, but about 70% of our activity is on the kind of thing that I talked about before, which is thinking about how teams' conditions help or hinder their work, what they can do in terms of optimising their workflows, their team interfaces with other groups, the equipment that they work with, the processes, systems, call systems. And so that's really focused, I think, on the outcomes of the health service. And I think if you're working for a health service, your sim has to be connected to those outcomes. It can't simply be that we're going to educate great healthcare professionals, because those healthcare professionals have to be able to work in the complex system. So to, I guess, return to your question, I've had quite varied roles in simulation. To my mind, they've complemented my roles as a clinician and someone interested in the outcomes for patients. And at the position where I find myself now, I can see clearly there's different ways that we can support healthcare to be better. Some of it is by the education and training of healthcare professionals, and some of it is about applying simulation directly to the complex systems in which we work.
Were you the first simulation director, educator, expert to have that organizational role for your hospital?
Yes, we didn't have a role like that before I came in. It came at a good time because we moved hospitals. We moved from a sort of smaller base hospital to a large tertiary referral hospital, which was much bigger, new services. So it was actually a good time. And there were a lot of services that were just new, that were interested in engaging with us to think about how to refine their processes. The trauma service was one, cardiothoracics, the children's critical care units. So some of these were things that the old hospital hadn't had. And so now there were new people and new systems and processes that people were keen to optimize. I think one of the things, Andrea, that we did that was probably the right approach, and it's been more effective than I realized it would be at the time, is we call ourselves a simulation service, not a center, not a program. And it's because I think we think about ourselves as being a both consultation and delivery service for other parts of the hospital. So we think about ourselves just like radiology or pathology or whatever. We've got a certain function that we then help other people in the hospital with, not we are a place that people come to get trained. And it might seem like semantics, but it's quite important when we think about our positioning and the impact that we're trying to have in the hospital.
I mean, this is exactly why I do this podcast. That is a mind-blowing idea. And it brings words to the problem that I'm having right now. Like, that is the issue, is we're viewed as this thing that's nice for the residents and the fellows. And I keep seeing that there's this huge potential to provide value to the organization, that organization that's sunk a lot of money into us. And it's all connected, right? Because when you improve the organization, when you improve quality and safety, you are improving resident and fellow education. Like, that elevates everything in the hospital.
Totally. I could not agree more. And when we do, say, simulations that do involve these trauma interfaces, the main people who are engaged in that and then under the pump, as it were, the consultants or attending level people who are the surgeons, the anaesthetists, the emergency physicians, the senior nursing staff. There are some residents and others who are there because they would be part of the team, but they're not the people making the decisions because they wouldn't be in the real world. Of course, they're learning, but what they're learning, Andrea, is not just, oh, this is how we manage a head injury. What they're learning is, this is how expert clinicians make decisions. This is how expert clinicians interact. This is how we collaborate successfully for individual and group patient outcomes. And this is the way we have good, respectful conversations about how we get better. And that, to my mind, is really what I want the residents to learn. Yes, they want to learn those other things, but I wouldn't be creating this big simulation for the residents to learn what is the dose of hypertonic saline in a head injury. That can be much more easily done in other ways. Whereas if I am thinking about putting in the effort for such a complex thing, it needs to have an organizational outcome. So to your point, and I've heard Paul Frampus talk about this from Wiser in Pittsburgh as well, we do need to connect the right language about how we frame up our simulation activities. And for me, simulation service has been one of those ways. But then also, as we think about our mission statement and our governance strategies, trying to in some ways remove ourselves from being under the wing of education, because that is a function, and instead being under the wing of quality and safety, organizational learning, or a number of other groups in the hospital, where I think actually we're better positioned if we want to be thinking about how to improve outcomes.
Mind blown. I'm just tickled pink to think of what we can do with that framework. I want to move to something else. And this is, in a way, my podcast is a very selfish thing where I invite super smart people on and I get to ask very vexing problems. I loved speaking with Eve Purdy last week and brought her a problem bag. This next one is a bit interesting. I have no clue what you're going to say on this, and I don't know if you have any papers on it offhand, but I'm guessing you would know somebody to talk to. I think I'm a veteran. And so part of my career was in the military. And there was something that happened during a simulation years ago that honestly was traumatizing for me. And I was very upset with the facilitator. And essentially, this individual recreated a mass casualty that had happened on his base as our simulation activity. And he was a first responder in that event. And he even made the patients very similar to what he took care of that day. And inevitably, people made mistakes in that simulation, right? Like people didn't put on the tourniquet fast enough or do a needle D or whatever we were supposed to do. And there was also a lot of limitations with the simulation. The fidelity could have been improved. And so I call them simisms with my learners. I assume they would have done the right thing, but we didn't bridge it. We didn't make the fidelity high enough for them. And he debriefed us really aggressively and hard and rudely, and not in a collegial, professional learning environment. And it took me years to really put together what had happened. And it took me interacting with a ton of more military people and being a veteran. And I'm almost certain that he had PTSD from that event. And he recreated that event at least tens, if not close to 100 times. And I think it probably worsened his PTSD. And the reason I'm asking you this question is I have a friend who just came home from a deployment that's a simulation educator. And a colleague sent her a message and said, I can't wait for you to share your wisdom with all the military residents. And essentially, we can't wait for you to recreate the cases that you saw there and bring back this cutting edge, what you've been seeing. And she was just like, I can't even imagine doing that right now. And it got me thinking, like, do we have any research on what that is? Do we have any safety best practices that we can give to simulation educators? Because on one hand, we're both emergency physicians, and the cases that were the hardest, that we hit our heads against the metaphorical wall the hardest, are the ones that we want to teach to, and we want to transmit those lessons. But on the other hand, we don't want to traumatize ourselves or our learners. So yeah, Victoria, just like solve PTSD in simulation.
Wow, what an interesting story. And a couple of things. Firstly, I'm not a therapist or an expert on PTSD, but there are such people. And I'm sure that the military has many advanced ways of thinking about that and dealing with that. And I think any of these people should probably talk to a professional about their own personal experience and what recreating that might do in terms of their coping. I think it probably is a smart thing to do, because the broader answer to your question is that simulation is a very powerful tool, and that we recreate, manipulate, and play with people's emotions at our peril. But we also can't ignore them, because that is also incredibly important and part of our experience as healthcare professionals, or in this case, in the military. So what I would say is, as a faculty member who may have had a bad experience, I think recreating it is probably, yes, could potentially be more about us than it is about the people that we're trying to help learn. From a simulation perspective, I think we obviously draw upon our prior experience, but I think faithfully trying to recreate exact situations is not very helpful for a few reasons. One is we can never recreate the context, as you said, whether it's sim artifact or whether it's just the fact that we have not got the same environment as we had. So we're not really going to create the same challenge as we might have had in that moment. Does that mean we didn't see interesting clinical things, interesting team things that we think are good challenges? Yes. So I think take our clinical experience as inspiration, but not for granular replication. Now, one of the authors I will cite here is a woman by the name of Cristina Diaz-Navarro, who is a European simulation person based in Wales at the moment. And she has written, I think it's about to be published, a beautiful document about recreating adverse events in healthcare and how we might do that through simulation. So there is a little bit of writing on that. It's less about individual PTSD or facilitators. It's more just about how would a health service recreate things. And I think they consulted widely and they've thought through the literature carefully. And I think there's some good advice in there about exploring prior events using simulation. But I think what you're talking about is, do we recreate something we've had? And I think we do that at our peril. I don't think we necessarily get what we're after. But I think the other thing is, why are we doing this? Are there important clinical things that we're trying to learn? Or is it that we had an intense emotional experience that we want to prepare people for? And now we start to look at the literature and people's experience in so-called stress exposure simulations. And the reality is that just trying to toughen people up by putting them through bad experiences does not necessarily make them any better prepared. We can make people better at their jobs so that it's less stressful. We can make people better able to recognize and maybe regulate and think about coping strategies for when they do feel emotional activation. Now, that's quite different to inoculating people against stress or emotional activation, because that simply doesn't happen and is not actually helpful. It is about recognizing, regulating, and in particular, regulating with the help of the team or the structures in which you work, so that you can preserve performance in the face of that emotional activation. So I think we do that at our peril. And I think what you described, the last thing I'd say is what you describe is why I don't think simulation is for everybody. A lot of people do it really badly. And what you're describing is poor preparation, poor simulation design, and poor debriefing to achieve any kind of useful outcome. And unfortunately, that's very prevalent.
Yes, you just summed that all up. And I want to dig in on, there's so many wonderful pearls there, but there was something that you said towards the end about, I actually had, embarrassingly, a lecture that I gave in 2015 called Stress Inoculation. And I weave that into simulation. And I've come to the same conclusion, obviously, as you. And my book that's coming out this fall is about emotional regulation in healthcare workers. I talk about sim some in that, but that's how I try to couch it for when we're doing those interdisciplinary sims. Like, are you recognizing when someone is struggling? In the relationship world, it's called like a bid for affection. There's moments in a team, and anybody who works clinically and is somewhat emotionally attuned, you've seen an overwhelmed person. You've watched them shake their head yes, and you see their eyes saying, I don't know what to do. And what do you do in that situation? Do you shame them? Do you ask a follow-up question or ask how you can help? I kind of thought, like, my career goes in these weird things. I do this emotional regulation work, and how is that informing my simulation work? But now I'm beginning to see those two converge back again in this really exciting way.
That is very exciting. And I think there's so much opportunity. And it's interesting you asked this at this point. Last Thursday, we did one of our stress exposure simulation activities with our ED team. And we've come to the conclusion, and as you know, we published on this, we just run our routine scenarios. And by routine, I mean they're challenging clinical scenarios. One was an airway thing and one was a cardiac arrest. So they're quite hard enough, but they're not out of the ordinary for ED teams. They're the kind of things that people find hard, but they're definitely not weird or wonderful. And so the teams do that, but we approach the session differently in terms of the pre-reading, the pre-briefing. We actually send things like Justin Morgenstern's beautiful work on stress and thinking about how we have coping strategies for that. So we actually frame up the whole session as this is about recognizing emotional activation, recognizing what the sources of that are, thinking about the impact of that emotional activation on our performance and that of the team, and then thinking about what we can do to mitigate the adverse impacts of that on performance. And so we send people pre-reading in that regard. We don't even send them anything about the clinical stuff because we figure, okay, fine, we can talk about the clinical stuff, but the debrief is all about exactly those points that I spoke about. And so what we end up getting into is exactly the kind of conversations that you have. How do you know that one of your colleagues needs help? How do you navigate giving that backup behavior? How can we use voice and body language to bring down the temperature in the room if we need to, or push it up if we need to? We've also seen underactivated teams when they perhaps should have been more activated. So thinking about how team affect is a thing, and also thinking about how we can manage that as a group. And that isn't, sure, people can do their square breathing or whatever it is. I don't mind people's personal physiologic strategies for dealing with emotional activation. But what we find over and over again, it is exactly what you talk about, the backup behavior in teams and recognizing how we can spread cognitive load more effectively. And those will be the things that preserve performance in the face of emotional activation, rather than just necessarily everyone thinking I need to lower my heart rate.
Oh, gosh, I could do this all day. I do have some rapid fire questions that I want to get to. But before I get into those, is there a question that I didn't ask you? We really didn't get to spend a lot of time reflecting on what simulation has meant to you. Is there something you wish I had asked you or you want to share before we move into the rapid fire?
Well, maybe one thing is who else we can continue to learn from as we're trying to improve our simulation to improve healthcare. And some of the work I've been doing recently is trying to think about how we connect with communities of practice in quality improvement, in safety science, in implementation science, and in complex adaptive systems. We've had quite a bias towards the learning sciences as the foundation for our discipline, but maybe some of the psychology sciences. But I think there's some others that we can potentially connect with. So I think there's some exciting things to be done in finding friends who are in design thinking, for instance. And if we want to redesign the cognitive aid for anaphylaxis in our hospitals, we should be working with those people, using some sim, using some design principles, engaging with some of our teams, bringing out the tacit expertise, rather than merely thinking this is about writing a cognitive aid and then training people how to use it. So I think the exciting thing for me right now is thinking, which other groups can we be working with to improve what we do so that we can improve healthcare professionals' outcomes?
Oh, that is just so exciting and exactly what we need. And I think the reason I'm lighting up so much is it's optimistic, right? I feel like so much of healthcare right now is very pessimistic. And so one of the questions I had written when I was prepping for this is what makes Dr. Brazil optimistic about the future in healthcare?
Well, mostly what I see is the great people in it, clearly. Yesterday, I was doing a faculty development exercise for some of our nurse educators who work around the hospital on how to use VEMS, our visual enhanced mental simulations, kind of desktop simulation, laminated patients. Quite an easy to deliver modality of simulation, still lots of thought put into it. But what really inspired me and made me optimistic is the educators who were there were from such diverse groups, and they were working in renal dialysis. One of them worked in the kidney bus that actually goes around and helps people transition to home hemodialysis, and who also provide a chair in a bus for people who are on holidays so that they can actually go further away. We also had people there from orthopedics. We had people there from complex care. And I just thought these are the staff that are just bit by bit helping their own staff be better at their job, be safer at their job. So what I'm optimistic about is you look at these people and they're all got so much effort and investment in the outcomes for them and their patients. And I think that's easy to forget when all of us in healthcare end up having an actually quite narrow existence. But one of the best parts of my job is I get to see the broad range, and you see just what great people we have got. And as we walked out of the workshop, I said to Eve, I don't think healthcare deserves the people who are in it. We really have such great people. So that's the reason to be optimistic. I, like many others, do share some concerns about the systems in which we find ourselves. And unfortunately, some of those just are going to require some political will. We can't, from the ground up, change some of the things that are getting in the way of that brilliant optimism by individuals turning into good outcomes for patients. So we've still got work to do.
As I like to say to my team, we have lots of job security.
We're going to be needing it for a while.
Right. So with the rapid fire, what are you most proud of in your illustrious simulation career?
I think the thing that I get the most satisfaction out of is the fact that I've had a lot of people now who've been sim fellows, peer educators, registrars, and others who have spent a 6 or 12 month period with us thinking about how to use simulation to improve healthcare, whether it's through education or translational methods. And I think those are the people that I feel has been the most satisfying, to think that they are going and then finding their own way and doing some really useful contributions around the place. So that's probably the bit that I find most satisfying.
I love that. You watched, at this point, I would dare say maybe thousands of healthcare teams, certainly if you add your clinical and simulation. What's the biggest leadership pearl that you would give to a team leader out there?
I would say listen. And I mean that in a few different ways, because I think it's like the adage, 2 ears, 1 mouth, maybe keep it in that ratio. I think team leaders are often inclined to share their mental model with their teams rather than to recognize the mental model is there. Attune to it, and then think about what you need to do to shape it to achieve the strategy that you're trying to achieve.
What's the biggest followership pearl? I don't think we talk enough about the followers, people in the room.
The pearl is you get the leadership you deserve and the leadership you ask for. So to put that in perspective, often in sim debriefs, we might have some followers, so-called, saying, oh, we didn't get enough recaps from the leader. And my question usually is, what stopped you asking for one? So really thinking about, how do we get the most out of our leaders? And there are things followers can do that are highly effective.
Well, this has been an absolute joy. How can our listeners connect with you?
I'm very happy if people ever want to email me. Of course, on LinkedIn, if people want to do messages and things in that way. I do have a website, drvictoriabrazel.com, which has a little contact thing if people are interested. But always interested in talking to people about sim stuff. European people, we're going to be at CSAM in June at the European Conference for Simulation. So yeah, lots of ways to catch up and have good conversations. You read my mind. A new question I'm trying out is asking people about conferences that they're going to be at. And I love Europe and I love sim. I'm not going to make it in June, but I'm going to shoot to be there in 2025. I'm going to shoot really hard. So I got to start moving my sim conferences around. I'm always at IMSH, which I love IMSH, but I'd love to check out Europe. And I've never been, A, never been to Australia, B, never been to any of your conferences. And Eve mentioned you've got one coming up as well. Yes. So if you really want to come to Australia and you want to come to the sim event of the year, you should come to Simulation Reconnect, which is a 2-day seminar that we have at Bond University. It's going to be on Wednesday, the 27th of November. And we've got speakers coming from Norway and from Singapore. But it's just a very cute little 100-person odd conference at Bond University. And we prioritize the networking. It's called Sim Reconnect for exactly that reason. We do have some talks, but we really think about the opportunity to share, particularly in those people who are involved in simulation, advancing healthcare in health services. So yeah, we like education to do, but this conference is particularly, the speakers this year are Hege Østdal and Siren Rettendal from Stavanger in Norway, who have done a lot of the work on helping babies breathe and taking very simple simulation strategies, but quite nuanced and clever systems in which to do training to Tanzania to help neonatal resuscitation. And then the other group who are coming are from Singapore, who have done a comprehensive and such an impressive job of using simulation to test their new Woodlands Health Campus in the north of Singapore. Beautiful new hospital that has been tested using simulation from beginning to end. And so they're here to tell their story. So if people are interested, Simulation Reconnect, and we'll have our promo for stuff for that out. And you should come, Andrea. We would get you to talk.
Oh, goodness. This has just been an absolute joy. I thank you for what you contributed to emergency medicine, to healthcare and to simulation, and the role modeling that you've done for people like me. Healthcare is hard right now. And I began to see simulation as a career path in part due to the work that you did.
Thank you, Andrea. That's super generous. Right back at you, though. I think thank you for the opportunity to be here, and also how great that you are highlighting work that various people are doing around the place, because we don't get to hear enough about what others do.
Absolutely. Well, thank you.
Thank you.
Thanks for listening to Heartline, conversations with healthcare changemakers following their heartlines. I'd so appreciate it if you could take a quick moment and hit the like button and also the subscribe button that you'll find within your podcast app or platform that you're listening on. It also really helps if you can leave a review. I would certainly appreciate a 5-star review and a few comments about what you liked about this podcast. Don't forget, you can also forward this to people in your network. People love getting new podcasts and changing up what they're listening to. So sending a podcast to a friend or colleague, or even to start a conversation about a change that needs to happen in your organization, is a great way to be a change maker. This podcast represents the views of the host and guests. It does not represent the views of any entity we work for or with. It is also for informational use only and does not replace any professional advice, including medical or psychological. If you are interested in unlocking your true potential, reach out to me. If you're an organization interested in supporting the well-being of your people, I'd love to connect on innovative solutions. Schedule a strategy session at andreaaustinmd.com. Sound editing services are provided by Better Podcasting Services, and you can find their website at betterpodcastingservices.com. And I'd also like to thank our future Dr. Caitlin Din, who is the production assistant for this podcast.